Hi, and welcome to a new episode of Dysphagia Matters. We have Dr. Sarah Gorst and Dr. Nicola Harman from the Core Outcome Measures and Effectiveness Trials Short Combat Initiative as our guests to talk about core outcome sets. Before our own postgraduate research projects, we had never heard of this before, so we figured this might also be the case for you. So keep on listening, because we think core outcome sets are extremely valuable for dysphagia research and for providing the best care for our patients.
Hi, Sarah and Nicola. It's so great to have you on today's episode.
Thank you. It's great to be here.
Would you mind briefly introducing yourselves to our listeners?
So I'm Nicola Harman. I'm a research associate at the University of Liverpool with a background in clinical trials methodology, in particular core outcome set research.
And hi, I'm Sarah Gorst. I'm also a researcher at the University of Liverpool, but I also work as the Combat Initiative Project Coordinator. So I'll say a little bit more about that in the podcast, but generally my research focuses on the development and uptake and methodological work relating to the development of core outcome sets.
Okay, great to have you here. We've invited you to talk about the core outcome sets, or short COS. But first of all, could you clarify what outcomes are and why they're important in research?
So essentially, an outcome is something that you want to measure in clinical research to find out whether your intervention is effective, but also it should take into account harms of that intervention as well. So if we think about clinical trials, there's a famous quote from Peter Tugwell that trials essentially start and end with outcomes. So their choice is really important.
And is there something like most commonly used types of outcomes?
I think it probably depends on the treatment that's being tested and the health condition for which the treatment's being developed for. I don't know if there's any standout ones that lead all others. Some common ones could be things like survival, pain, quality of life, maybe hospital visits or admissions, could be adverse events, but it can differ so greatly depending on the intervention that is being tested or the health condition or the treatment.
Okay, so now that we know what outcomes are, what is the challenge with outcomes in clinical trials?
So I think the key challenge, there's two really that core outcome sets relate to in terms of outcomes. So the first one is that trials measure different things. Trials for the same health condition, for the same intervention that take place in maybe different parts of the world, or even in the same parts of the world, can measure different outcomes or measure them in different ways. And what that means is then when you want to look at all of the evidence in an evidence synthesis exercise, it's difficult to compare and combine that data. So it leads to waste in research. So you've got different outcomes being measured. That's the first problem. The second problem is around reporting of outcomes and outcome reporting bias. So sometimes a clinical trial may measure a range of outcomes, but not report on all of them. They may only report on outcomes that show a significant change, for example, or the ones that the researchers consider to be most interesting. But then we're not getting a full picture, and some of that data isn't published. So you've got heterogeneity in outcomes, different outcomes being measured in different ways, and also potentially outcomes being measured but not reported.
Everyone who has looked at applied outcomes in clinical trials and dysphagia interventions might have noticed that researchers choose different outcomes and define and measure them differently. From our own work and from colleagues, we know that it doesn't really matter if you look at clinical trials in the pediatric population or at trials in critical care, head and neck cancer, or Parkinson. So how can we solve this problem?
The problem, so as Nick has gone through, they could be solved if basically of all studies for a particular health condition, used the same set of outcomes as like a minimum set, and they could all be then compared and combined. And so this would help to reduce waste by making the best use of all research.
Chalmers and Glasio estimated in 2009 that 85% of all health research is being avoidably wasted. You might think that can't be right. Given that $200 billion per year is spent globally on health and medical research, this implies an annual waste of $170 billion.
So when this set of main outcomes has been agreed for a health condition, it's called a core outcome set. And then if all studies then measured and reported this minimum set of core outcomes, we could bring them all together to get a better understanding of what treatments work best.
And in what way would this reduce research waste?
So when people are running like different clinical trials, you need to, at the end of it, draw all the evidence together.
Like in a systematic review?
So in a systematic review, a meta-analysis, you can pull all the findings together. So you've got a stronger evidence base to show what works best. And obviously, if studies are measuring different outcomes, this just isn't possible, because you could have one treatment that is looking at one outcome, something looking at another. So you just can't weigh them up together. But if they're both measuring this core set of outcomes, we could then see how well they're working, so you can compare, different studies with each other.
Yeah, okay. And is there like a definition for a core outcome set, or how would you describe this?
Yeah, so it's an agreed standardized set of minimum outcomes that should be measured in all studies, all clinical treatment for a particular health condition or intervention. And there's just a real emphasis on that it being the minimum set. So the aim of a core outcome set is not to restrict what is measured in studies and trials, but rather to say that if everyone measures this minimum core set, then we can then compare them. So it wouldn't have to be, the primary outcome of the study. It's just as long as they're measuring these core aspects, we can then pull them together.
Yeah, so depending on the specific research question, researchers could add other outcomes that are of interest to them, but this minimum core outcome set should be really measured. So in the end, you can really compare it, synthesize it, and conduct actually systematic reviews and meta-analysis.
Yes, definitely.
Do you have an example in mind of a cause for like any field?
So there have been core outcome sets. Sarah probably knows the exact figures on this for a really wide range of health conditions. I think, Sarah, would you say the rheumatoid arthritis core outcome set is a good example? So that was developed by the OMERACT group, and it's a good example of a core outcome set that's been developed and then how it's been taken up by clinical trials in that research field. With, I think in the last review, there were about 80% of trials that were then using that core outcome set. And that was a few years ago now, so that number may have increased again.
Wow, that's a lot.
Do we know, or do you know, why the 20% of other clinical trials haven't used this cause?
There's work going on around core outcome set uptake. It's a really important question, because there's obviously a lot of work that goes into developing the core outcome sets. And if they are to reduce research waste, rather than actually contribute to it by creating a core outcome set that doesn't get used, we need to understand the enablers for use for researchers, or what the challenges are for implementing a core outcome set. So I think it's a good question, but it's actually a really big research question. What helps researchers either find out about the core outcome set, that it exists, and if they know about it, what are the reasons for using it or not using it?
One problem might I'm not sure that researchers actually don't know about the existence of core outcome sets in general, so that they don't even look at if there's one out there?
Yeah, that's true. So we do at Comet, we try and publicise core outcome sets as much as we're able to do so. But yeah, a lot of people won't have heard what a core outcome set is. So we do try to make those aware, and it's also those who are developing the core outcome set. It's also their duty as well to make sure that before, at the very beginning of the process, that different, like the critical stakeholders in their field and wider as well, know what they're doing and the importance of it. And it's why we try and develop resources to help explain what core outcome sets are and why they're important.
So Comet, I think, has also done a lot of work around working with, for example, trial funders to endorse the use of core outcome sets. So when somebody is applying for research funding, there's a question that says, are you using a core outcome set? And if not, why not? So that there's another, point of dissemination there about, what core outcome sets are, that somebody, if they want to get that money, is hopefully going to go and find out what a core outcome set is, look in the Comet database to see if one exists for their particular research area, and then hopefully apply that to their research.
Yeah, so maybe because you've mentioned it already a few times, maybe could you explain what the Comet initiative is?
Yeah, so Comet is basically, the main element is we have a publicly available, online, freely accessible resource where we store basically all studies relating to the development and uptake and other related work relating to core outcome sets. We ask basically people who are interested in developing a core outcome set to get in touch with us to let us know that they are either planning this work or they've commenced this work, so that we can register it, and then anyone else who is maybe thinking of developing a core outcome set in that area can see this work is already ongoing. And it's also published work, so we do an annual review to identify published core outcome set studies. And we also have alerts that come through basically weekly to let us know. So we try to keep it as up to date as possible. And it's also, so it's not just those who are developing core outcome set, but also those who may be running a clinical trial and thinking about what outcomes to measure. So they can check our database to see whether a core outcome set does exist and see. But in addition to the core outcome sets, we also have various resources. So as Nick mentioned, Comet does a lot of work with trialists and trial funders and other authorities. So there's details on there about all of those different groups who endorse Comet and where you can find their guidance. And then we also have resources for including patients and the public in core outcome sets and other guidance documents. So anything that we can think of that can help people to develop a core outcome set and develop them well, which is really important. And then also the next stage, which is ensuring that the core outcome sets are then used. So like the rheumatology core outcome set that Nick mentioned. We're always, if anyone has any ideas of other things that might be helpful, we're always open to suggestions and other resources that can be developed.
Yes, definitely. And I think the website is really helpful. So COMET actually stands for Core Outcome Measures in Effectiveness Trials. And for everyone who's interested, the website is comet-initiative.org. And we will link it in the show notes. So feel free to check it out. So at the moment, there's only one completed course for dysphagia interventions in critical care and was conducted by Sallyanne Duncan and colleagues. And Beatrice Manducci, our guest from episode 6, is currently working on a course in the head and neck cancer population, whereas myself, I'm developing one for Parkinson's disease and dysphagia interventions. Do you mind explaining what the main steps in developing a course are?
So the first step is to decide, is there actually a need for a core outcome set? That's your very first thing. So you may want to look at the COMET database to see if something already exists, but also you can get that information from, for example, previous systematic reviews or meta-analyses. And often, if there is an issue of heterogeneity in outcomes, that will be reported as a challenge in undertaking that systematic review or meta-analyses, because they can't, for example, access data for some of the outcomes that they've chosen. So if you've got a need for a core outcome set, your next step is to find out what outcomes have been used. So this is typically the approach that we take. So find out what outcomes have been used, and we can do this through a systematic review of the outcomes. So then we'd extract from included studies what's been measured, and also at this stage it's useful to extract information on how they've measured it. So a core outcome set, your first stage is what is critically important to measure. But the next step, once you've agreed that, is how do you measure those things? So thinking about that early on can help you later in your core outcome set development. So once you've done your systematic review, you've extracted your outcomes, you end up with a long list, usually a really long list, that you work with people. Often we work with somebody, so people in a steering committee, a study steering committee, that includes relevant stakeholders, including patients or their carers, to think about that list and combining outcomes that might actually be the same thing, but they're worded slightly differently. And then also thinking about how you describe those outcomes so that they can be interpreted in the same way and understood by the stakeholders taking part. And so when I talk about stakeholders, really what we're thinking about is who is going to use the results of research to make decisions about treatment. So that as a minimum, so there are standards for core outcome set development, which are really helpful when you're looking at the stages. So they are COS-STAD, so there's standards for development, and there's COS-STAP for your protocol. There's also COS-STAR for when you come to report. So if we think about the standards for development, it would typically be health professionals, patients and or their carers, and researchers in the field as your minimum. You may also want to include other groups, for example, healthcare policymakers. So you've agreed your stakeholders, you've got your list of outcomes. The next thing you want to do is to seek consensus between those different groups of people on which ones are critically important to measure in all future trials, which are the most important outcomes. Often we do this using an online Delphi survey, which is a method of seeking consensus with multiple rounds and feedback between rounds between those participants. And then after the online Delphi survey, we would do a consensus meeting to review and ratify the results of the survey with a smaller group of people where you can have more detailed discussion. So at the end, you should end up with your core outcome set. And like I said, it's not the end. That's what should be measured. It's important then to think about how each of those outcomes should be measured. Sarah's just been working on a project to do that. Do you want to talk about the steps of the how project, Sarah?
Yeah. So as Nick said, once you've agreed the what, you then move on to this how stage, and you really want to start off by identifying the existing measurement instruments or definitions for each of the outcomes included in the core outcome set. And as Nick said, when you're looking in the what stage for the outcomes that have been measured, it's really helpful then if you could be drawing some information on the instruments, so you haven't got to go back and do it all again. You may need to update it because obviously other studies will have been likely done since you've done that review, but at least you've got a starting point to go off there. So you can find out what's been, as you do with the what, find out what outcomes have been measured. You find out what tools have been used to measure them. So there could be questionnaires, performance measures, could just be definitions. So there's quite a variety. And then once you've, similar to the what stage, you'll have a long list of measurement instruments. And it's at this stage you then want to perform like a quality assessment of these instruments. And so this would involve assessing the measurement properties and the feasibility aspects. And you can find out more information about this on the Cosman website. So whereas COMET focuses on typically on the what to measure, Cosman looks on the how stage. So it stands for consensus-based standards for the selection of health measurement instruments. And the group, they're based in the Netherlands, and they've got really helpful resources on their website. And COMET and Cosman have produced the consensus-based guideline together, and that can be followed. So it's a step-by-step guide of the process of this how stage. And then once you've done like this quality assessment, you then ideally want to, as with the what, use a consensus process to finalise the recommended outcome measurement instruments and definitions. So the study I'm involved in at the moment is for long COVID, and we're running a Delphi survey. So rather than asking participants to rate the importance of outcomes, we're asking them to do this for the outcome measurement instruments, and then hoping to narrow that down, and then similarly a consensus meeting at the end. So we're trying to follow a similar process to the what. It's a bit more complicated to work with measurement instruments than outcomes, but it's going well so far, and hopefully we can produce some guidance to help others who are thinking of doing it in a similar way.
Okay, thanks for that explanation.
To give you an example, Sallyanne Duncan will briefly explain how she developed the course for dysphagia interventions in critical care and what the final course actually looks like. Hi, Sallyanne, and welcome.
Thank you very much. My name is Sallyanne Duncan. I am a speech therapist and a PhD student based at Queen's University in Belfast, and have developed this international core outcome set for dysphagia trials in critical care. So the aim of this core outcome set was to achieve international consensus on a minimum set of outcomes for dysphagia intervention trials with adults in critical care. And the scope of our project was quite broad. We wanted to include any dysphagia treatments that would treat or prevent dysphagia in adult patients who are or have been mechanically ventilated. In the methods section, which you've probably already heard about the what and the how of core outcome sets, we wanted to answer both of those questions. What are the core outcomes that we need to gather, and how and when will we measure those outcomes? So in stage one, we answered the what question by gathering information sources from our published systematic review, but also from discussing outcomes with 64 speech and language therapists who worked in critical care settings from 53 different ICU units here in the UK. We also discussed treatment outcomes with 4 ex-ICU patients who had all experienced dysphagia during their intensive care stay. From those information sources, we generated 30 outcomes, and we put those into a 2-round online Delphi survey. The patients, the clinicians, and the researchers all rated the 30 outcomes. We eventually reached consensus on 6 core outcomes. The 6 outcomes identified were aspiration, severity of aspiration, swallow function, efficiency of cough, pneumonia, and mortality. The second stage of our methods was to decide then on the 6 core outcomes, how and when to measure them. So again, the how was really looking at what measurement tools or what instruments or rating scales would we use to measure each of the outcomes that were identified. And we took those 6 outcomes and we brought them forward with our set of definitions and measures and time points to the consensus meeting. The consensus meeting was completed by clinical trialists from ICU, core outcome set developers, as well as critical care researchers, critical care clinicians that were multi-professional, and patients.
Thank you so much, Sallyanne, for this quick overview.
Thank you very much.
Let's just imagine that I would like to do a clinical trial on, for example, dysphagia intervention in the pediatric population. So I go to the COMET initiative website and look for a cause, right? If there's already existing something. What if there isn't? What if there's not a cause available? What could I do to make my study or my trial still as high quality as possible?
So obviously you wouldn't necessarily go down the route of developing a core outcome set just for your trial, although some might. You may build something like that into your funding application, where you could say, before we do this trial, we want to make sure that we are measuring relevant outcomes, relevant and important outcomes. So that's one step that you could think about is, could you embed that work and then go on to the trial? I think one of the really important things that a core outcome set does is it seeks opinion of those stakeholders, of those people that will use the results of research. And you can still do that even without a core outcome set. When you're designing your trial, you can involve those people in helping choose which outcomes to measure. And for me, I think that's, a relatively easy step that you could achieve for a trial even without a core outcome set in place. Sorry, one thing I didn't say in the how the steps to develop your core outcome set, I mentioned a systematic review to identify what outcomes have been measured, but that's not the only step that you might take in developing your outcomes list. You may also do qualitative interviews with patients or indeed health professionals, or you may do a qualitative synthesis of the literature, the relevant qualitative literature. So you could look at those sorts of things as well when you're developing your trial protocol.
Yes, definitely. And by this, you would already implement at the very first stage the opinions of patients and carers, for example, because like you said, the problem is at the moment when we look at clinical trials, oftentimes the key stakeholders like patients and carers weren't involved in designing what outcomes to measure. So when we do this systematic review and we look at what outcomes have been measured in the past, we only have the opinions or the views of the clinical researchers oftentimes and not of the patients and carers. So doing this qualitative research work at the very first stage is really helpful to comprise all the views of all key stakeholders. Right. Absolutely.
And it's certainly something that we've seen in core outcome set development as well, where, early on, the involvement of patients might have been slightly different, and we've seen as patients have become involved or even brought in, and I think this was for the rheumatoid arthritis core outcome set, bringing patients in then at a later stage after that initial core outcome set, then bringing in more patient input, identified another outcome, which was fatigue, as being critically important. So it added to that core outcome set and brought in that patient perspective. So yeah, definitely something that's important to do is to get input from your patients and carers.
Yeah, great for this little introduction into what outcomes are and what core outcome sets are. And for me personally, it's really interesting, obviously, but I think, whoever wants to learn more about it, it's really helpful to go to the COMET initiative website. And maybe to summarize, what are the advantages of core outcome sets and what are the challenges?
Well, obviously, we see many advantages to core outcome sets, unsurprisingly. So they allow you to compare and combine the outcomes that are used in different studies, as we've said. So you can determine whether or not a treatment is effective. And because we're able to do this, this consequently helps to reduce waste in research. As Nick said, the point of core outcome sets is to reduce waste, but we need to make sure that they're used. So that could be looked on as not a disadvantage, but something where an area where there needs more work to help ensure that they're used. So if core outcome sets have been developed according to the minimum standards, which are available on the COMET website, as Nick said, so i.e. you've included appropriate stakeholders, you've used suitable methods to reach the finalised core outcome set, you can ensure that the outcomes that matter are the outcomes that included those that mattered to all relevant stakeholders. In terms of disadvantages, I don't know if there really are any, or whether I just wouldn't say what they are to put a negative stance. Because by developing a core outcome set, you're not restricting what can be measured, as we've said, because they're just a minimum set that should be measured in all research and or practice, depending on the scope of the core outcome set. So we should say that some core outcome sets are developed just for research studies, others can be developed just for use in clinical practice, and some can be developed for both. And so that's something that people need to consider at the very beginning of their core outcome set development process.
Yeah, maybe it's not really a disadvantage, but a challenge. Like you said, it's a minimum of outcomes that should be measured. But for example, if one outcome that, because there's like a criterion that needs to be met for being included in the cost. So oftentimes it's like 70% consensus in an outcome to be included. So if it's, for example, 65%, it might not be included in the final cost, but still 65% of the stakeholders thought it was important. So maybe is that something that we need to consider if we do a clinical trial and look at the outcomes, and there are like 5 final outcome measures in the course, but those are not necessarily all the important outcomes that I need to measure, but there are more.
Yeah, that's really important. With the core outcome set, the outcomes that reach consensus for the final inclusion, they need to have been voted in, so to speak, by all stakeholder groups, so patients and health professionals. And so there can sometimes be where, if you've gone for the 70% threshold of meeting it, it may have met it for one group and not others. And then, Nick, we've recently had it in a study we've been involved in. I know it was something that you flagged in the paper. I don't know if you want to say a little bit more about that and those types of outcomes.
Yeah, so and I think transparency in reporting is important for core outcome sets, so that you can identify those outcomes that maybe one group thought was critically important and other groups thought were important, and they didn't meet that inclusion for being in. So we had that with one study. There were 2 outcomes, 2 symptoms that were critically important to patients, but across the stakeholder groups and in the process, they didn't meet the definition of consensus, so they weren't included. But what we flagged is that I think quality of life was included as an outcome, and actually these symptoms were having an impact on quality of life. And so you may want to consider in the how stage of choosing how you measure outcomes. So for example, how you measure quality of life may take into account those 2 outcomes, those 2 symptoms that were impacting on patients. But it's really important to flag that, that information is there. These were critically important, and there may be ways to measure them that don't create additional burden, because you have to balance in your trial your outcomes, the burden to researchers, the burden to patients. But yeah, important to flag where there are those important but not critically important, or only critically important in some groups. And then can make a decision on how best to manage those. And the other thing is that a core outcome set isn't necessarily static. It's not a case of it's been developed and that is it until the end of time. That is the core outcome set. Often we can look at who was involved, where did participants come from, what countries were represented, did they represent different models of healthcare, for example. And then, you may want to expand on that core outcome set and think, well, actually, we need to involve a broader group of people and review that core outcome set at a later date. So it's a minimum. Doesn't mean those other things can't be measured. If we're transparent in our reporting, then researchers can identify those other things that they may want to consider. They may do some patient and public involvement work that says, absolutely, you have to measure that in your trial, and they add those on. And we should be mindful of the need to review and update core outcome sets.
Okay, thank you. I think that core outcome sets, or the whole theory behind it, is such a big topic and also quite complex. So thanks for the short introduction and explanation on all this. Is there anything else that you would like to add? Did we forget to talk about anything?
One thing I'd just like to, going back to the disadvantages or challenges maybe, it's really important for developers to, as Nick said, the way it's an ongoing process where it may need updating, it's also critical that developers think about the dissemination of their core outcome set and ensuring that people are going to use it. So, because it's all well and good developing it really, really well, but if, as you say, like not everyone's aware of core outcome sets, or never mind just your one specific core outcome set. So developers and others need to do a lot to make sure that people are aware of core outcome sets, your core outcome set, and that it gets used. And that's why I think personally that the steering committee that you put together to advise on the development of your core outcome set from those initial stages, it's really important to have key groups involved who have good links with professional and patient organisations who can see a real need for the core outcome set, and they can help publicise it widely and help to ensure that it's used later on once it's developed. So it's good for developers to think about that from the get-go, to be, rather than just wait till the end and think, okay, so now they've developed it, what shall I do? Because usually when you get to the end of a project, you're moving on to the next one, and there isn't always that time available. So throughout the process, just factoring those decisions into it can really help, I think.
Yeah, thank you so much. Thank you, Sarah and Nicola, and a big thanks to our listeners for following along. If you like, follow us on Twitter at dysphagiapcast or on Instagram at dysphagiamatters. And if you enjoy listening to our podcast, leave a review on Spotify, Apple Podcast, or wherever you listen to podcasts. Thanks so much for coming on the show, Sarah and Nicola. Take care, everyone. Bye-bye.
Bye.
Thanks. Bye.